Good morning, everybody, and welcome to your first session today. My name is Claire Ward. I am the chair of our National Equal Opportunities Committee. I do want to just give you a quick reminder about the Code of Conduct. Rosemary read it out to you before. I'm quite sure it will appear in the chat at some point. Okay, so today's session, this first session is on demystifying the types of causes of bladder issues and way to improve bladder health. And we've got two wonderful speakers for you today. The first person you're going to be hearing from is Peony Lee. She's the founder of Jude, which is a women's health company with a mission to bring better bladder care into the mainstream. She has experienced chronic bladder infection from a very young age and understood the barriers to better treatment and awareness. She's passionate about closing the gender health gap and has spent her working career building organisations that focus on women's health topics. Jude has successfully raised £6 million in funding to advance innovation and research into bladder health and has served more than 17,000 women in the UK to date. Her dedication also extended to distributing 6 million pieces of PPE during the pandemic to frontline workers and carers. We've also got Anne Henderson, who's a highly experienced consultant gynaecologist and the owner and director of the Amara Clinic based in the centre of Royal Tunbridge Wells. She has extensive experience in women's health and has been a consultant for 25 years, and I'm quite sure that you're going to learn more about her during the session. So I'm going to pass straight over to Peony and welcome her to the NESUWT.
Hi everyone. Thank you, Claire, for introducing us, and Anne, thank you so much for being here with us today as well. So good morning, everybody. First of all, I want to extend a big thank you to the Teachers Union, giving us an opportunity to talk about one of Britain's last taboo, bladder worries. We're going to make this session as interactive as possible. So let me share screen now and share with you a presentation that we're going to walk through today. So as Claire said, I'm Peony, founder of Jude. We will make our kind of round of introduction after introducing the agenda. So to start with, we're going to make this session as interactive as possible between me and Anne. At the end, we will have 10 minutes of Q&A, starting with an introduction. We conducted a new research on coping tactics, which we heard from Catherine and Claire that this has been a common, I suppose, strategies from the teachers community. Anne is going to talk a little bit about how do we spot these symptoms, what to expect from your GP. And we're going to start talking about lifestyle tips and guides that you can employ today and how can we support you. So with no further ado, so I'm Peony. I've been suffering from really chronic bladder infection when I was 14 years old, and it has been a few years of going from toilet to toilet. And at that point, I really thought my life is going to be like that. So throughout, actually 5 to about 7 years of my life, I've been to multiple GP appointments, tried out so many different, natural remedies, amended and altered my diet and lifestyle habits. And I finally found a new way to cope with my bladder issues. And I really want to bring better bladder care into the mainstream, which is the mission of Jude, now the UK leading bladder care company. And I'm so glad today that we have Anne here. And Anne, give us a bit of intro about you and the amazing work that you've been doing.
Hi, Peony. Thank you for the introduction, and thank you to everyone for asking us here today to speak about what is a really important matter, but often one that is fraught with embarrassment and stigma, and hopefully that will come across in our presentation. So I am a consultant gynecologist, and I have spent years both as a junior trainee and as a consultant treating women with a wide range of gynecological problems. My main focus now, and really has been a key theme throughout my career, is menopause, perimenopause and menopause. And I run my own clinic in Kent, the Amara Clinic, and I have a wide range of strings to my bow, so to speak. I do lecturing like this as well as treating patients every day. And one of the themes that runs through gynecology, but particularly perimenopause and menopause, is the association with bladder problems. Now, they may not be the main reason that patients come to see me, but within the huge number of patients that we see at the clinic every year, there's a huge number who have bladder problems as part of their menopausal issues. And HRT can help, but sometimes we need to look for additional support. So it's a really keen interest of mine, and that's why I'm delighted to be supporting Jude in their ongoing campaign.
Thank you, Anne. And I was telling you all about the story of my bladder infection. And so after sort of 2 decades, I found out that I'm only one of 2.3 billion people globally that also have bladder problems. And so if it affects one in 3 of us, why is it still a taboo? So our bladder remains to be an unsung hero, allowing us to live our lives according to our schedule, back-to-back meetings, 3-hour coach trip and journeys. And our bladder does take on the challenge time and time again until it stops working. Then we realize that we have taken this organ for granted. So for 1 in 3 women, a sneeze, a belly laugh, or a cough can end up with a side order of a bladder leak, which is called a stress incontinence. Sometimes that is kickstarted by life events, such as childbirth, as Anne also said, menopause, but lifestyle factors. So today, what we want to go into is talking through all different symptoms of different types of bladder issues and what can you do about it. Before that, we have conducted a new research with YouGov and a nationwide study to show our population have been deploying some very common coping tactics to avoid the inconvenience. You might have seen in the last few months, there are so many news about the lack of public toilets by the Lib Dem. And so we went one step further to look at the health implication of this issue. What we found is actually a silent public health crisis that is emerging from the lack of public toilets or the lack of opportunity for us to access toilets when we need it. So 58% of our population use deliberate dehydration to avoid the need to go into the toilet. And that increases 65% for the 25 to 34 years old. 56% of our population hold and wee for up to 3 hours because of the lack of access, and that goes up to 5 hours for 27% of 18 to 24 years old. So it's not just an age issue. If you can see here, actually, it go across the board. 37% avoid going out of their homes or hesitated or cancel an outing because they weren't sure if there are toilets around. So, when we talk about loneliness, when we talk about obesity, when we talk about, all these different health issues, we can see coping tactics like these are definitely really damaging. Another quite innocent coping tactic is called the just in case we might think it is quite a smart tactic because when I was young I was also taught just in case, let's go to the toilet before a trip, but actually that is quite dangerous and also quite harmful to our bladder when we go to the toilet as often just in case. When our bladder is not full, it does train our bladder to empty as often as possible in the future, even if it's not full, could be a cause of overactive bladder. So that is also another common coping tactic that is not very healthy for us. And so if any one of you have, used these coping tactics before, it'll be a really good time to sort of keep track of them because we also know from our survey, this new research, 41% of our population know or suspect these coping strategies have led to and caused health issues such as UTI, bladder issues, meaning incontinence and overactive bladder, kidney problems, and also other problems. And unfortunately, women have had it worse than men. So we can see 67% of women have deployed deliberate dehydration compared to 50% of men. 42% of women have avoided going out compared to just 33% of men. And the most striking stat is 33% of women know or suspect these coping strategies have led to UTI, whereas only 18% of men have. And so this is particularly an important topic for us women to pay attention to our bladder health. And so now we're going to start talking about, when do we need to pay attention? When do we know we need to pay attention to our bladder health? And I would love to invite Anne to talk a little bit about symptoms and spotting these symptoms.
Yes, thank you, Peony. So there are key symptoms that we need to think about, and overactive bladder symptoms are very different to stress incontinence symptoms, which we'll also come on to. Overactive bladder is exactly what it says on the tin, really. It used to be called detrusor instability, which is the medical term for the detrusor muscle, whereas stress incontinence, which we'll also touch on, really refers to the bladder neck or the bladder sphincter. So there are two key muscle areas in the bladder. Overactive bladder generally refers to the main bladder, that is the muscle which is the main supporting muscle. And when that becomes overactive, essentially it is contracting without need. So it's contracting when the bladder essentially is not full and when it really isn't appropriate or necessary to be emptying the bladder. And there are a wide range of symptoms that can result from this. One of the first ones, which Peony has already covered, is frequent visits to the loo. The bladder is determined to empty even though we don't want it to, and even though it's not necessary, and it takes control, demanding visits, sometimes as frequently as every 30 minutes throughout the day in extreme cases. And there can be other triggers to empty, which again are not determined by the bladder being full. That's the key thing to take home. The bladder is not functioning normally. It is determining when it empties rather than following standard pathways. So latchkey incontinence is where you're arriving home, you're going to open the front door, you're putting the key in the lock, hence latchkey, and the bladder knows that there's a loo in sight, usually just a few yards away, and it's already gearing up to empty. And that can mean that you actually leak before you get into the house and reach the loo. And because we're talking about overactivity here, this is not within your control for the most part. This is the bladder taking over and functioning autonomously without listening to proper signals. Similarly, at night, the vast majority of adults with a healthy bladder, with good bladder volume, of course they can go overnight without getting up. The bladder can hold hundreds of mils, and it's extremely unlikely that it's going to fill with hundreds of mils overnight unless you've drunk a crazy amount. So getting up overnight to pass urine is generally not a good sign. It could be a sign of poor bladder health. And again, it's the fact that the bladder is doing its own thing. There may be many other triggers. One of the classical ones is the running water sign. And I know from my own experience as a gynecologist and speaking to patients that if you're going to examine someone, if they've got a prolapse or bladder problem, and you run the sink to wash your hands, to clean your hands before you put on gloves, that often triggers the patient who's lying beside you to go to the loo. And not uncommonly, they say, oh, I have to get off the bed, I have to go to the loo before you examine me. And that is a subconscious link between running water and the signal to pass urine. And again, as with all these triggers, it's out with your control. And finally, we've got hormone and menopause related problems where there is a genuine change in bladder quality. Estrogen is key for building collagen. And as we all know, estrogen levels start to decline in our 40s onwards. Perimenopause starts usually early 40s. So by the time you hit menopause, you can have lost significant collagen, not just from the bladder, but from bone, skin, cardiovascular system, and so on. And the bladder suffers as well. And if the bladder muscle thins, it is going to be less resilient and more prone to irritability. So that really is where the hormone link comes in. And then we have stress incontinence, which is a very different condition, although there is a degree of crossover. So stress incontinence is more of a physical incontinence. So to some extent, there is control. So anything that puts pressure on the pelvic floor, sneezing and jumping and laughing all sound very different, but they have a strong link in common in that you are increasing the pressure within the abdomen. So you're usually bracing the rectus muscles, which control the abdominal strength. And that then pushes pressure. Pressure's got to go somewhere, and it generally goes downwards into the pelvic floor. And particularly the bladder sphincter, or the outlet to the urethra, which, as I'm sure you know, is the pipe, the passageway that passes from the bladder to the outside. Now, this is different to the bladder muscle in that it is, to some extent, under our control. It's controlled by the pudendal muscle, and we can contract the bladder outlet. If you do your pelvic floor muscles, that's what you're doing. You're actually closing off the sphincter muscle. So there is some control over leakage, whereas with the other type, the overactive bladder, it's usually uncontrollable. And where we've got problems with sneezing, jumping, laughing, straining, exercising, anything like that, it's because the bladder outlet, the neck or sphincter, is not strong enough to tolerate the additional pressure coming through from those activities. Now, that may be menopause related again. So menopause isn't a fan, the bladder rather isn't a fan of menopause. Loss of collagen because of declining estrogen levels, never a good thing. But there are many other activities which damage the pelvic floor. We know many of them: trauma, childbirth, even just being pregnant is not good for the bladder and bladder neck. And anything which is likely to affect the pelvic floor, the hammock which supports the bladder and bladder neck, that could be being overweight, having chronic constipation, having a chronic cough if you're a smoker or asthmatic. Any of those can do chronic damage over long term, resulting in this bladder neck or sphincter deficiency. So women should expect a lot from their GP, and not just their GP, but the NHS in general. Women who go to the surgery may end up seeing a practice nurse, and many services are delivered by highly experienced nurses with continence training called continence specialists. So this doesn't generally just mean the GP. I would recommend going sooner rather than later. If you have symptoms for 3 months or more, that's a good ballpark figure to consider getting help. The GP will obviously want to take a history from you, the length, the duration, the severity of your symptoms. Are there any risk factors, such as the ones that we've just discussed? Is there a history of urinary infection? Is there a history of other bladder problems, things like bladder stones, kidney stones, and so on? So these will all help to paint a picture to explain what may be going on. What you need to understand is that urinary urgency and frequency and urinary leakage are not a diagnosis, they are symptoms. And when you go to see your healthcare practitioner, whether that's a GP, a nurse, or a gynecologist like myself, we are there to make a diagnosis for you and then treat that diagnosis. Symptoms do not necessarily give you a diagnosis. And one of the easiest ways to explain this is that if you have stress leakage when you jump, cough, or sneeze, that could be because the bladder neck's weak, but it could also be because you have overactive bladder. So there is a crossover between those two conditions and the symptoms you experience. And it's very important not to jump to the wrong conclusion, because the treatment options for these conditions are very different indeed. So the basics include things such as excluding underlying health problems, looking at risk factors, looking at your bladder diary, what you drink, what you void, when you void, looking at the episodic frequency of continence. Is this a weekly problem? Is it a daily problem? Is it an hourly problem? How much is it disrupting your life? And then moving on to do any tests. These might involve doing tests to check for infection, scanning tests to check for bladder abnormalities, kidney abnormalities, even blood tests to check for general health conditions, and then moving on to establish treatment, which could be medication, it could be physiotherapy, it could be bladder drill, so managing incoming fluids and outgoing fluids, and eventually it could be referral on to a specialist for more detailed tests.
Thank you, Anne, for a very, very comprehensive walkthrough around what to expect from your GP. You mentioned about the bladder care diary, and I would love to actually do an interactive, I suppose, session with you. And this is my bladder care diary, and I want to quickly let everyone know what that is. It is basically a logging the type of drinks that you have, the quantity, if you have urine or urination, frequency and quantity. Do you have leaks? Do you have urge? Do you need to change your pad or clothing, or what activity you're doing? The reason we do a bladder care diary is because that help you and your GP to identify habits, your daily habits, and pinpoint some of the issues that you might be experiencing. This also act as a suggestion, I guess, an evidence for suggestions for you to change some of the lifestyle habits. So I would love to actually do the session with you now, Anne. So I have two kind of myths about my own bladder problems. First, I experienced stress incontinence. I thought I experienced stress incontinence. And I also thought that my symptoms are because I have a small bladder. So I went to Anne and I gave her my bladder care diary. And Anne, it'll be great to kind of start walking me through, if you can, just based on this, what you see and how can we explain this to everyone?
So if we break the day down into the 2 hourly sections that you've shown, we can see that the water intake, fluid intake, is very sporadic. It isn't regularly throughout the day, and there is a considerable volume of water being drunk at what one could argue is the worst possible time, which is around midnight and early hours of the morning, when in an ideal world you should be asleep. Sleep is good for the bladder, and drinking last thing at night, especially as large a volume as a pint, is probably one of the worst habits that one can follow. And just as a general piece of advice, the bladder is a very habit-driven organ, and that's good, but it could be bad. So if you can get the bladder into good habits, it will be your friend, and it will help guide you through management of overactivity. But if you don't get the bladder into good habits, and you follow the pathway that you see on this chart, the bladder will respond with bad behavior because it's very habit driven. And it can take months to break bad habits. The bladder, it almost has a Pavlovian response that you need to break through willpower, if you like, and through good practice. So do not get into bad habits. It would be my main advice. So here we've got a good volume over the 24-hour period, but it's not taken in a sensible and regular manner. So the bladder is filled gradually during the day and then can void and fill and void. If you have restricted volume followed by a huge volume late at night, you're giving the bladder the wrong signals. The other thing that I can see here is that we're drinking 2 stimulants. We've got coffee and black tea, which it doesn't say if they're decaffeinated, so I'm assuming they're not. Caffeine is not a friend of the bladder. Neither is alcohol. They are stimulants. Alcohol causes dehydration. Caffeine actively encourages the bladder muscle to contract. So it's not going to help you if your bladder is already overactive. People forget that fluid is not the enemy of the bladder. Fluid is the friend of the bladder as long as it's the right fluid. And the bladder generally functions best on around 2 litres of fluid a day. That's not 2 litres of coffee. That's generally 2 litres of bland, non-irritant fluids, such as water and anything else, decaffeinated tea and coffee, absolutely fine, but not stimulants. So that would be my first comment in column 1. And again, column 2, you can see there's a very erratic pattern of urination, clustering in the afternoon, and again overnight as well. That's called nocturia, when we get up to pass urine overnight. That is not a sign of good bladder health. But you can see there's a link between the fluid intake and the voiding, and then the fluid restriction as well. So this is giving us a lot of signals about how we can change the bladder health. And again, if you look at the columns on the right, we've got the working pattern, which seems to be when someone's working intensely, they're focused, they're forgetting about hydration, they're forgetting about voiding on a regular basis. And these are the sorts of patterns that you have to introduce into your daily life.
And thank you so much. Now that I really have to hydrate myself a little bit more, because I do know I'm very guilty of not drinking enough water, and I love a cup of coffee a day, but it is diuretic and it is a stimulant for our bladder. And I always thought that I have a small bladder because every day, in the day, I, have very frequent and small volumes of urine. But actually at night, I do go quite a lot and larger amounts as well. And just by looking at the activity that I'm doing, you can already know that I'm a busy person that is always working. So there is quite a lot. The good news, I think, is that there's quite a lot that I can do, and I can take control to change my lifestyle habits to make my bladder as a friend rather than something that is going to hold me back in life. So as you guys can all see how important actually recording these habits, making a 3-day bladder care diary is so important to pinpoint some of these kind of unhealthy and healthy behaviors. So can click here to download our Jude Bladder Care Diary. It's completely free. You can also call us in this number to get a free lifestyle consultation, just pointing out and analyzing with you what are the sort of hours and timings. But do kind of keep in mind that we're not going to make a diagnosis from Jude's point of view. So definitely approach your GP with this 3-day diary, or approach Anne, and they can give you a proper analysis about your bladder health. But this is a very good starting point. And if taking this diary to your GP is going to also shorten the amount of time for your GP to clearly diagnose what is going on. And actually 80% of the women that we know, that is our customers and patients, don't really know what causes their symptoms. And when that's not discussed, when you don't have that sort of knowledge or power, it's difficult for you to know where to start. So this is a very good starting point. And Anne, it will be really great for you to also kind of walk us through some treatments and potential treatments for bladder issues as well.
Yes, Peony. So the good news is that there are very clear guidelines which healthcare practitioners should follow for management of bladder issues. And these are guided by NICE, which is the government body, the National Institute for Clinical Evidence. And these guidelines are actually all available online. So if any of you are particularly interested in looking at the nitty-gritty, you don't have to be a doctor to access them. You can search them and download them. And as with all medical treatments, the plan is that we start with, firstly, the diagnosis, as I explained earlier, and then we go through a cascade of interventions, starting at the most minimal, the least interventionist, moving through moderate, intermediate to much more significant intervention, which may or may not include surgery. And of course, those interventions would not be done at GP level. These would be done in a specialist centre, often with a highly trained gynecologist who would be a urogynecologist. So those are gynecologists like myself, but who have additional higher level training in surgery and higher level interventions for bladders, bladder neck treatments, and so on. So there's a huge cascade. Starting with simple recommendations, we would start just with the bladder drill that we've looked at, bladder charting, looking at where you're going wrong or what you're doing right with fluid intake, what you can improve. 2 liters a day keeps you rehydrated, stops the risk of infection, and it keeps the bladder functioning normally. The bladder is designed to fill up to 300 to 400 liters, then empty, milliliters rather, then empty, and then fill, and then empty. It's not designed to empty after a very small volume has been inserted. So fluid is not your enemy. Pelvic floor exercises can be vital for both overactive and stress incontinence because they strengthen the pelvic floor, giving you more control over voiding in general. Admittedly, they tend to be more effective where there's stress incontinence, but they can be extremely beneficial for overactivity as well. And you cannot, my view, which is probably slightly controversial, is you cannot do these from a handout. You need a really skilled women's health trained physiotherapist pointing you in the right direction. These women and men are expert at checking you're doing the exercises properly. They measure your contractions on the Oxford scale, 1 through to 8. So they will be able to do internal examinations, check that you're doing the exercises properly. And you cannot do that from a video or a book or a handout. Face-to-face is vital for pelvic floor physio. And this is something you will do lifelong. It's not for a week or 2 or 4 months, it's lifelong. Whether you have surgery or not, if you need it, whether you're on medication, you do your pelvic floor exercises. We then move through into first and second line medications, some of which the GP can prescribe, some of which is not recommended for primary care prescribing. And the main group of drugs we look at is drugs called anticholinergics. And these are drugs which calm, in simple terms, they calm the bladder muscle down. The bladder is under control of the parasympathetic and sympathetic nervous systems. You can't control these. These are autonomous. But this group of drugs calms down the signals from the nerves to the bladder wall and stops the bladder contracting erratically and allows it to fill and then contract. And there are slightly more advanced medications, a new group of drugs called beta-3 agonists, which have fewer side effects and are more targeted, but need to be used appropriately and tend to be prescribed by gynecologists like myself or specialists with a higher level of training. But nonetheless, first and second line medications can be very effective. However, they are plagued in some cases by side effects such as drowsiness, constipation, dry mouth, dry eyes, and so on. So there has to be a proper discussion before starting them. And finally, we move on to procedures. We're looking at higher level treatment in hospital. That might include, for example, Botox for overactive bladder. The muscles are paralyzed or partially paralyzed, which explains why the muscle contractions in the detrusor muscle calm down. But again, it's not one and done. The bladder often needs repeated injections over a period of time, and complications such as retention, where the bladder just stops working, needing a catheter, can arise. So these are only used in very restricted cases where other measures haven't succeeded. And if you have a weak bladder neck, you might need surgery, you might need a repair, and possibly collagen injections and various other high-level operations that a specialist would offer.
So I also want to quickly kind of run through, and thank you so much for walk through all the different types of treatment. One issue still remains, which is, 4 out of 5 of us actually don't go to our GP because of the taboo, because of the lack of knowledge. But also there is this high side effects around medication, as you can see here. On the left-hand side, these are, the first-line medication, oxybutynin and anticholinergics, usually first-line medication. The persistence rate after 3 months is actually quite low, meaning on average about 50% of patients leave their initial medication just after 3 months because of the side effects that Anne just talked about. But also there is this elephant in the room around procedures and surgeries that is, involved with stress incontinence, and that is the mesh surgery. And it would be great for you to talk a little bit about that and really break the sort of stigma around it. So then we encourage more people to seek for treatment.
Yes, so the mesh debacle, which probably was, as a gynecologist, I can comfortably say has been one of the greatest scandals to hit medicine in the last couple of decades, I think has done a great deal of damage to the security and willingness of women to come forward for bladder help. Although the mesh scandal only relates to women with stress incontinence and pelvic floor deficiency, that message often didn't reach the general public. And if you're worried about your bladder function and you don't understand the nuances between an overactive bladder and a weak bladder neck, and why would you, unless somebody's explained it to you, you might live in fear that you might end up with mesh. And you can't have escaped the media coverage over recent years. There's been mass action against many trusts, many gynecologists, both in the private and NHS sectors, who were inserting mesh called a TVT or a transvaginal tape to treat stress incontinence. And although in some hands it was highly successful, unfortunately, the bottom line is that far too many surgeons jumped on the bandwagon without appropriate expertise and training. And it was seen as a quick fix for stress incontinence, which is an incredibly common problem. And many such cases were done inappropriately or incompetently or even with negligence, resulting in life-changing damage to women where the mesh eroded through the vagina, through the bowel, possibly resulting in colostomies, removal of bowel, major surgeries, infections, sepsis, and unbelievable outcomes which should have been avoided had there been proper care and attention to case choice and training of surgeons. So we've moved on from that, and mesh, I'm delighted to say, is virtually never inserted now, except in extremely rare cases after very detailed discussions for obvious reasons. But the damage is there, and I think it has left a very dark cloud over the subject of incontinence. And it's not helped by the fact that, as you can see from this chart, even one of the best medications available, which is solifenacin, this is the one on the left, you've barely got 60% of women who are able to tolerate the medication for 3 months. We're almost looking at a 50% dropout here for the best medication, let alone the worst. And if this is something that you have to be on lifelong, otherwise the symptoms of overactive bladder are going to recur, you can see why this is not a straightforward problem to address. And even with decent medications that are widely available, we've still got to face the issue of side effects. So overactive bladder continues to be a challenge, as does all incontinence. And we need to just keep searching ahead again and again to get better medications that are more targeted, with fewer side effects and better compliance rates.
And thank you so much, Anne, for putting this so in such a succinct way. We face a multifaceted, I guess, challenge when it comes to women who experience bladder issues, from past surgeries to current day medication that still have a lot of side effects. to even waiting for the NHS to give us, second line medication or more advanced treatment. Sometimes it can last for a year, up to 3 years of waiting time on the waiting lists. And so that is one of the main reasons why I started Jude. It's because I do believe there's a lot of things we can do in our individual power, meaning the bladder care chart, changing our lifestyle habits. We have raised about $6 million, as Claire has said in the beginning, investing into more research, innovation, development in nutrition and diet, and how we can improve our own bladder health with solutions that are more accessible. And also, of course, partnering up with organizations like the Teachers Union to uncover and reveal this issue. So the next section really talk about the actions you can take today to improve your bladder health. And some of that Anne has already really kindly put it forward in the beginning of the session. So there are bladder stimulants or irritants, as we call coffee, tea, like what I drink every day, cola, soda, alcohol, citrus fruits, chilies, spices, chocolates. They all can be bladder irritants. And what we suggest is keeping a log and see what foods you have taken and you have consumed that then lead to more irritation and overactivity. And then you can identify that is an irritant for me. Some of them can be for you and not for other people. So we would recommend cutting it down, experimenting which is the irritants for you. Again, hydration, really important, but also the timing of hydration. Like myself, if I like to hydrate, late in midnight and before my bedtime, I obviously will wake up in the night and go to the toilet. But constant small sips of water throughout the day is going to help you dilute your urine in your bladder, lead to less irritation in your bladder. The good news is that there is bladder-friendly diet that you can embrace. There are bananas, pears, green beans, actually a lot of seeds and nuts are also amazing for your bladder health. And they are overall really good Mediterranean diet for your heart health and your overall body health. There is particularly a food through our research that we found is called pumpkin seeds. These are very clever, unassuming seeds that have an efficacy over reducing bladder overactivity. So they have been used across decades by doctors in Europe, and they prescribe them to patients under this, what is called a traditional herbal remedy, THR license for their patients. And what it does, it is releases naturally occurring nitric oxide in your body. It doesn't just relax your blood vessels, but it also relaxes this overactive detrusor muscle in your bladder. So you experience less overactivity. And through our research, what we do as part of Jude isn't just, webinars and workshops and resources, but we also have our clinically proven, powerful natural botanicals to relieve bladder overactivity and stress incontinence. It's first of a kind supplement. They contain up to 70 pumpkin seeds in one daily dose. We have already served more than 18,000 UK women. Till date, we launched our company just about a year and 10 months ago. And so what we see is that women have experienced a life-transforming, results, not needing to wake up at night so often to go to the loo, but also they feel a stronger sense of bladder control. What this also contains is a phytoestrogen, a plant-based estrogen, as Anne started to talk about menopause-related incontinence. As women stepping into our perimenopause and menopause, we lose a lot of estrogen. They are, amazing at stimulating collagen production. So what we have in our supplement, as some women, like to substitute that with plant-based estrogen, that stimulate collagen production in your pelvic floor, in your bladder lining, giving you more sense of control. So we have a clinically proven, we have conducted this formulation in a double-blind, placebo, and a randomized controlled trial to prove out the efficacy around daily urge. So it is, very efficacious for reducing leaks. Other tips around bladder care. So bladder care in the bathroom. So we already talk about just in case wheeze that we should avoid. But also there is a right way to go to the toilet. There is this proper pee etiquette, and that is elbow on the knee. That way you are more likely to empty out your bladder fully. And so it doesn't irritate your bladder just after you have, a urination. The third one is go with the flow. So never force your pee to come out or avoid holding in your wee for long periods of time. If your brain is telling you that you need to go, if your, bladder is full, go with the flow, don't force it. And so how can we support you? We have a free community. We have now about 5,000 women in a Facebook private community called Jude and Friends. We have a Dr. Mazrat there moderating our conversation, but you can also hear so many stories about women experiencing bladder issues, but also embarking on their journey of better bladder health through diet, through our supplements. We also have a bladder care handbook and the Bladder Care Diary, and a range of products here, from our supplements to a very modern absorbent underwear to fully compostable plant-based pads and liners too. So how do we find us? For Jude, we are jude.com. This is our hotline that you can call to speak to a trained specialist about your bladder care diary, but also about your symptoms. We don't give any diagnosis, but it's confidential. You can talk to us about your bladder symptoms. We have a Facebook community called Jude and Friends. And Anne, tell us a little bit more about how can we find you?
So we're based in Tunbridge Wells, and anybody who's interested can have a look at my website, Gynae Expert. We obviously have face-to-face appointments, which is what I would recommend for anybody with bladder problems, because you generally do need at least one examination during the clinical process. But if that's not feasible, we can always start with a virtual consultation, either by telephone or video link. I work with a team of wonderful female GPs. We have a practice nurse as well, and they're all very knowledgeable not just about menopause, but also about other bladder issues as well. So we're very happy to hear from anybody who feels they may be frustrated perhaps with the NHS. And I do have huge sympathy for my colleagues who work on the NHS. The GPs who work with me in clinic all have NHS practices, so we're not entirely devoid from sympathy for the NHS. But if you feel you would like a longer appointment and you want somebody to explain the problems and make a diagnosis, we're here to help.
Thank you both again very much. I'm sure your session this afternoon will be equally as well received. There's been a lot of comments in the chat. I do know that. So if you do have any questions for Peony or Anne, if you want to send them into the equality team, then we'll try and get some answers for you. But thank you very much. And the next session is going to start at 12 o'clock. So enjoy your break, and I hope to see you both again this afternoon. Thank you.
Thank you, Claire, again.
Thank you.